process. As we potentially move into the negotiation process, we do wonder what that transparency will look like. We know that negotiations with the federal government can often be a bit of a black box. And if that's going to, so I guess first of all, we would encourage to keep having these discussions with providers, with consumers, with payers, so that we can all be well informed and marching to the same beat as we go forward. But if that's not possible, then I would propose that we do all sit down and come to some sort of agreement about what terms are there that we would walk away from, because I think there is a big concern about this being a little bit of an unstoppable force as we keep moving each step forward. And I think that could be relieved if we do have agreement on certain things that we're just not willing to negotiate. And so with that, I will see if there are any questions.
Thank you. We'll hold board member comments or questions till the end, just so we make sure we get through everyone. But thanks for being available for that. Trey Dobson, Dr. Dobson.
Thank you. I'm just trying to figure out how I can add additional comments to this. So I'll just pivot from what I plan to talk about, and I'll just move towards maybe my perspective as a doctor rather than as a chief medical officer. So by the way, I'm Trey Dobson. I work as a physician at Dartmouth-Hitchcock Medical Center half-time, and then half-time at Southwestern Vermont Medical Center, and then the other half-time as the chief medical officer, which somehow equals a full FTE. I'll just support three things. I just wrote them down real quick that people have already said. A little bit different perspective, again, not from a chief medical officer, but from a doctor at the bedside. The first is really ensuring these services that Pat talked about in the initial presentation that are outside of a hospital. So now I'm focused on global budgets and how these other services impact. So let me start by saying, 20 years ago when I started, or let's say 15 years ago, I would be practicing and I'd come in to work in the morning or overnight, and there would be, typically like one or two patients in a 20-bed emergency department that we really didn't have a great place to go. We were trying to figure out where to get them, and we'd eventually get them somewhere in a really long amount of time, like 12 to 16 hours. But that's quite different today. This is what Dr. Merman was talking about, and I think Judy alluded to. When I go into work tomorrow, so tomorrow I'll go into the emergency department, and just picture this. There's 20 beds, 5 to 7 of them will be occupied by people that have been there not 12 or 16 hours, but more like 24 to 36 hours. And we tend to really feel for those patients and talk about, the difficulties in those patients, and that's true. But what we don't talk about is we've now just taken out 5 to 7 beds, taken them offline, and now we're trying to operate an emergency department with 15 beds. So the capacity is much more limited. And if you think about this, you can run these numbers. So all the CFOs on this will enjoy this. You get about, in our emergency department, 75 patients per day. They're coming through 20 beds. Of course, they don't all come. They don't come in a nice uniform way. They all come around noon. But the point is that we've got 20 beds to work with. Well, now we only have 15. The patients occupy the beds for 2 to 3 hours, except these others that are occupying it for 36 hours. What happens is all of a sudden the math just multiplies tremendously, and we have patients waiting in the waiting room who need to be seen. And that's really contrary to what people think. People think the emergency departments are clogged by ankle sprains and sore throats, and it's just not the case. I can see those patients in the hallway. I can see them quickly. It's the beds being occupied by individuals that we really don't have a place to put them. And then when the sick people come in, we're really stuck because we can't put those sick people in the hallway. I said I wasn't do this, but I'm gonna give this terrible analogy. It's a steady state in an emergency department and in a practice. You can kind of use these analogies for a practice, but think about when you get on a ski lift, and as the day goes on, the line backs up a little bit, but hopefully in Vermont, not Colorado, the line doesn't back up too much, and there's a steady state flow. But if you took out every 10th chair, what would happen is the line would just keep getting longer and longer and longer. There's no way to fight that because there's not enough chairs. That's what's happening in emergency departments right now, and in an inpatient setting where they can't be discharged. All right, there's my terrible analogy. Second thing, Pat, you didn't talk about this much, and I know I've seen some of the material, but there was a little bit of alluding to penalties or some type of incentive for avoidable utilization. And again, I will come at it from an emergency medicine perspective. This stuff is really baloney. It's based on claims data, and it says things like if you have a headache, that's an avoidable utilization. Well, I don't see a lot of minor headaches, but by the way, if I do, they're really easy to deal with. I see difficult headaches. If I see a sore throat, it's typically fairly difficult. They should be in the emergency department. We have an urgent care center. We have primary care centers. They go to those places that the patients self-select. So if we're going to penalize, or if any of the model talks about penalizing hospital systems based on what they call avoidable utilization, we're really double whammying these systems, especially the ones that have poor access and they can't help that. Because if you're in a capitated model, you already are incentivized to put the patients in the least cost environment. So it really hurts. Like, I'll just make up, let's say you have a hospital with terrible primary care access. It's hard to recruit in. You're all working. A lot of people use the emergency department. You're trying to deal with it. And now you're double penalized for this. So I just hope we can avoid those. And I'm not saying that I know that those are included, but if they are, let's get away from them. In fact, in a capitated system, I'm not sure why you need to penalize and reward much behavior anyway. It should be built in. And then last, everybody's talked about it, but I've got to say it, the complexity is real. Let me just come at it from a physician standpoint. In the 70s, 80s, 90s, and even up into the 2000s, we made medicine more and more complex, longer algorithms, more exceptions, how we can deliver care, and I don't know why, but a very complex way. The real reason was people thought it was better quality if we could do things really complex, bring in tools that make it where we're trying to deliver the best care to the individual in front of us. But what happened is that increased cost, and it really decreased the quality because it's impossible to reproduce this easily. And the same thing can be true when we come with complex models that we're trying to do for payment reform. If we simplified it, it may be slightly more expensive, right, on the direct cost, but it's a lot less expensive in the long run, and easier to reproduce, less prone to error, easier to understand, easier to motivate the staff to do what we want them to do, which is focus on patient care. I know this has been said, but I just take it one step further. That's it. Thanks.
Thank you very much. And sometimes there is a little bit of overlap, but I actually find it really valuable to hear that people have the same thoughts. To the extent that there is that, I think it's actually valuable for the board for those points to be emphasized. Last but not least, Mike Fisher from the Healthcare Advocate.
Thank you, Chair Foster and Pat Jones, Director Jones. I really I agree with what you just said. It's really important to hear this conversation. It's not, this whole effort is not just certainly not a waste of time, because I think whatever happens at the end of this, I think there's a lot of clarifying that's come through. You've heard me say it before, and I'm just going to say it again, that it's premature to say that we should either do or not do a HED. Indeed, the decision of whether a HED makes sense for Vermont is going to require a real detailed analysis of the costs, much of which, or risks, much of which have been really explored today, and the benefits. I think it was Judy Fox who said it clearest. What are the terms? Is there an opportunity for an improvement of how Medicare participates in Vermont? At the end of the day, that's the question. And I appreciate everyone who's spoken today from the provider community and Blue Cross, and now for me, the Healthcare Advocate, the two non-providers in this list. I agree with much of what's been expressed. Some of the early panelists talked about the need for a broad all-in approach. In the early days of the global budget tag, there was a lot of talk about that, that in order for this to be successful, we had to have, as much as possible, all providers and all payers participating. Just to go back to the cost-benefit analysis I just talked about, if only 1 or 2 Vermont hospitals are poised to participate, the potential benefits of an enhanced Medicare payment would be that much less. So that will feed into the analysis. I agree with the concerns expressed earlier and just now by Trey Dobson that that the push to reduce avoidable care has its risks. And I'll just say from an advocate's perspective, in the absence of a non-hospital, of an adequate non-hospital provider system, the push to reduce avoidable care in the hospital system could easily result in pushing people to an absence of care. Obviously, I'm going to say, need to say clear and upfront that yes, from our perspective, affordability and access is key here. At the end of the day, this has to be experienced as an improvement to the Vermonters who struggle to get and stay healthy. I think it was Blue Cross who said it clearest earlier. It's essential that we establish a clear data collection and analysis methodology to be able to analyze whether the model is having a causal impact on the outcomes for Vermonters. What hasn't been said earlier is that I fear, or I believe, we're not set up to do this. And I fear that we won't be set up to really do this kind of analysis. So that's a concern of mine. It's really hard to answer the question of what we would or could be doing if we were not working on this HEAD model. You know, the what is the plan B? I think there's been a lot of discussion earlier today about many things that need our attention. And I'll just say, I'll just sort of recognize, people know my origin is as a frontline social worker. So I go back to my roots. There are things we're doing that we're maybe only scratching the surface on that we could be doing a lot more of. As an example, a SASH or a SASH-like model, low tech, simple, bringing care and care coordination to where people are. If we did more of that, I'm talking many-fold more of that, I'm confident we would have good outcomes. We would improve care. I want to just name a dynamic that's clearly right in front of us. Many of us, maybe all of us here, have heard each of the board members, each of you talk about your concerns. Honestly, some of the same concerns expressed here today. As the administration approaches the negotiation with the federal government, they need to have an honest and clear assessment of whether there's going to be a path to a majority vote in favor of what comes out at the end of the negotiation. It would be a shame to put all that time in if there's a hard stop at the end. And I'm not suggesting that there doesn't need to be a hard stop. I'm just recognizing the dynamic. The challenge with the concept I set up front, that the deliverable has to be worth the effort, is a recognition that it will take, that it is taking many millions of dollars of contractors' time on top of the efforts of everyone in this room and more to get to a place where we know those details. After 10,000 hours of Pat's time, Pat, I don't know how you have that much time, and all of the other efforts, we need to be ready to walk away if this isn't right. That's not going to be easy, but it really needs to be said that we need to be ready for that, or recognize it as a potential outcome. Finally, the last point I'll make is what's the rush? I know there has been a decision from the very beginning that we should be in cohort 1. And so I just ask that question as we do this very, very tough analysis and consider all the complexity. Does it make sense for us to be in cohort 1? Is there a scenario where, you know what, to get it right, to really evaluate whether it makes sense for Vermont, it's going to take us more time? thank you, board members and everyone here. I really appreciate the conversation.
Thank you. I have a couple of questions and thoughts and things to share with the group, but I'll open it up to the other board members first.
I can jump in. Thank you, everyone, for joining us today. It's always interesting to hear everyone's perspectives, and as the chair mentioned earlier, where there are common shared thoughts and where folks differ. And I don't really expect people to answer this today, but one thing that would be super helpful from my perspective is to get people's perspective on a topic that one presenter brought up, which is how doable is healthcare reform without Medicare participation? Again, that requires some thought, but I think that is the question that we also need to start thinking about moving forward over the next year as we develop more information about the AHEAD model. So I'll just throw that out there now so people have time to start thinking about that. Thank you.
I could pop in. I think I have 9 pages of notes. Just can't express the appreciation enough for everybody to take all the time and sit through this hearing with us all and share your perspectives. I don't know, I kind of, as I was going through, thinking maybe I would just highlight a few things and just things that caught my eye at the time. But you know, Dr. Jacobs and Rick Dooley, especially, but also Jessup Barnard and Mary Kate, John, just really the importance of primary care, the need to support primary care ahead, know ahead. I'm sure Trey agrees with me, working in the emergency departments, that primary care access has really been a huge challenge lately, and the importance of high quality primary care, and I feel strongly about advanced primary care in our healthcare system is just, it's foundational. So but I guess that's where I'll leave it. I really appreciate everybody taking the time and putting in the analysis and the thought, and I hope this is the start of a conversation that continues, because clearly there is not an easy right answer in this scenario, and there's a lot of steps to get to what is the potential best case scenario from AHEAD. And also, I think really thinking about several people mentioned this idea, but not so much a plan B, but what is going to be the plan for hospitals and parts of the system that are not participating in AHEAD from the get-go. Maybe they come into AHEAD, but there needs to be we need to have some rational idea of where those parts of our system are going to lay with regards to Medicare and the other components. So thank you, everyone.
I think it in the interest of time, and I know everybody has been so patient and this has been such a fruitful conversation. I think I'll just say I so appreciated everybody's thoughtful insights, the concerns, and the gratitude that was expressed by everybody. I think we heard this several times. It's complex, and there's so much more that we have to learn. And your insights and I too have pages and pages and pages of notes here, so I appreciate that, and I'll be looking back at that. I think the comments here will help us all ask better questions, do better analyses, and potentially either negotiate a better deal or know better when to walk away. So I just want to express my gratitude for all of that, and I think this is going to help us tremendously, and I hope this is not the end of this conversation. As we learn more, as we have more of these public meetings, I hope that there'll be more participation. in those meetings or sending public comments separately. Help us from your perspective, make the best decision for Vermonters. So just expressing my gratitude, and we have a lot of work to do. Thank you.
I'd like to take a moment to express my gratitude as well for all of you spending time with us this afternoon, and the amount of thinking that you put in preparing for this meeting. And like my colleagues, pages and pages of notes. And I heard consistent themes about the complexity of the model that we're looking at, how burdensome that may be. I heard consistent themes about the need throughout our state to be focused on primary care, mental health, some substance use disorders, and affordability and access. And hearing those consistently brought forth, I think will help us stay focused on those top issues as we move forward. So thank you all for your time.
I'm just going to share a couple quick thoughts. We've been hearing for years how successful the CPR program is, how much of a lifeline and support it is for our primary care. And then I heard so much about the complexity and the burden and the risk of the AHEAD model. And I really was kind of consistent theme. And I thought about the success of CPR, and it's really quite a low-tech program. It's a very, very simplistic, low-tech solution that we hear routinely is incredibly supported by the provider community. Low risk, low tech, highly effective, short dollars, very, very short dollars. And yet everyone really, really raves about how critically important it is. Kind of similar with Blueprint and SASH, not incredibly expensive for the bang for our buck that we've been getting as a state out of those programs. There's a lot of information about, well, this program doesn't do this and we need this, and there's going to be all these downsides. But from our decision, when ultimately we have to make votes and decisions on this, even if it doesn't do, the ultimate calculus is, what are the costs if you don't do it, and what are the benefits, right? Like, how does that play out? So at some point, whenever anyone wants to reach out or talk to me, and I'm always around, I'd be curious about how we view and should evaluate the cost of losing the waivers, the cost of losing the primary care money, the potential cost of losing the Medicare savings money, which God only knows how much it will actually be and how it will actually flow and how it will be realized, and the costs of losing the flexibility, the predictability, and the savings if there are potentially avoidable use. So putting those components together, the costs and then what we're actually going to lose if we don't do it, is sort of where I get a little bit stuck. I think on the flexibility, predictability, transformation, I have to say that at this point, I'm less bullish on those than I was 9 months ago. And I say that because at this point, 2 hospitals have non-binding letters of intent. There hasn't been overwhelming interest from the commercial insurance side or from the hospital side necessarily, maybe for great reasons. But the scope of this is quite narrow. And then as to Medicare money, it's looking pretty slim. So if it's 65% is sort of the rough estimate of driving change and opportunity to actually transform and change incentives, we're quite a bit below that. So as the chair of the care board, I start to think about how much money we're spending on this and the time we're spending and our staff that we're spending and Ms. Jones and everyone at AHS. And I do worry about something I think Blue Cross and the HCA and others said, which is the politics of spending millions of dollars investigating and understanding this and making sure that we all keep an open mind that it could be the right thing to do and do it if it is, but also walk away from having spent millions of dollars and hundreds, if not thousands of hours of our own time doing it. And that might be a really painful decision. But the other decisions, we might have to do it even if it doesn't solve every problem we all know exists. So that's in the back of my mind as I sit here and work with everybody. The comment about discernible changes and outcomes, I think that's really important. We have to plan for that and allocate for that and provide resources for that. We didn't have it in the all-payer model, and we need to make sure we're thinking about that going forward. The regulatory burden and all of that will be very expensive to set up. We don't have the resources at the board. Hospitals and providers don't have the resources to on it if it's a very small impact. The last thing I'd say is that in terms of Plan B, I think Plan A is hospital transformation of the 167 work. I think it's really, really critical to understand what gaps we have, how they can be filled, and where there's overlap and opportunity to save money in terms of our infrastructure. So I've always viewed that as Plan A and being maybe the most important thing we do in the short term. And the other thing I'd say is I'm curious what people think should be alternatives that we should be investigating and thinking about. Is it rate setting? Is it reference-based pricing? Is it site-neutral payment? Is it simply trying to get Medicare to pay better for primary care or for preventative care or for certain services? So I'd be curious on any thoughts on that topic as well. But that's really all I had, and I did want to echo everyone's incredible appreciation for what you all did for us today. Tom? You're muted, Tom.
Sorry. If we're going to be asking this group to help with our thinking, one of the things that I'd appreciate help thinking about, the all-payer model tied some successful program funding for some successful programs. It blended all that together. The CPR, Blueprint, SASH was dependent upon having an accountable care organization and participating in the all payment model. Funding through AHEAD would continue supporting those programs. If we're not selected for the AHEAD model, or we choose not to participate, what other funding mechanisms could make up those losses? How could we continue these programs if we are not participating in a CMS program? I think being selected is uncertain. Our choice to participate, if we want negotiations to reflect our needs, these are non-trivial risks that we will not participate. We will not be a participant with the AHEAD model, and that may compromise some of the financial support received by the CPR program, Blueprint, and SASH. So what mechanisms can we come up with to continue funding those? I think we should be spending some time thinking about that, and I'd welcome any phone calls, emails, thoughts about that.
Right. If we don't do this, we will lose a lot of things people really value and appreciate that we've had through the ACO model. I'll take public comment via the raise the hand function, if there is any. Ms. Gutman?
Yeah, I just
Hi.
want to say this was another great discussion. And I do appreciate the board for taking all these comments in and listening to them intently and taking notes and so forth. I am encouraged. I have great hope that Vermont really is going to get the best system because of just this, the input that you're receiving from multiple areas of the healthcare system. So thank you.
Thank you very much, Sharon. Any other comments? Probably won't be much because we had 14 panelists. Okay, I don't see any else. So everyone, thank you. And we're around email, phone call, whenever you have thoughts and you just want to share them with us, please continue to do so. And thank you. All right. Any old or new business for the board? And is there a motion to adjourn?
So moved.
Second.
All in favor, say aye.
Aye.
Hi.
Aye, we're adjourned. Thank you. Have a nice afternoon.
Thank you.